Patient advocacy there's two levels of patient advocacy, isn't there? There's the individual level where you're advocating for the individual in front of you, and then there's a role that GPs may have, or certainly the college has, in trying to advocate for patients more generally. But it's about helping patients navigate healthcare, which can be very daunting. And Jenny Poppy from Lancaster calls primary care a holding environment, a space in which people can reflect on their decisions and choices as they search for appropriate support to help them manage and or resolve their difficulties. And that's included signposting to services, welfare and benefits advice, being very close to GP surgeries. And again, thinking about vulnerable groups and trying to be a voice for vulnerable groups who may not have a very strong voice. And in the number of different types of people that might fall under that banner, there are some particular groups with a very quiet voice, like people with learning disabilities and so on, that need to be advocated for. So, some challenges. I mean, I think, I'm sure there's nobody here who's not aware of the particular challenges. I mean, we know that poverty is persistent and demanding. And my personal view is I didn't doubt the last government's commitment to trying to address inequalities, and yet, you know, if you look at the stuff that Mike's shown us and so on, not a great deal of change happened. And I think that demonstrates just how difficult it is. We also need to be aware that it's demanding and hard work for professionals working in these areas, and we need to understand that. So there's higher demand, there's shorter time available for people, there's greater psychological and physical morbidity, more multiple morbidity, and greater GP stress. Part of the problem is the relatively flat distribution of general practitioner manpower across the spectrum, despite a 2.5 to 3-fold increase in the prevalence of health problems in more deprived areas. And in some areas, and NHS Hull has experienced that, recruitment and retention of GPs has been very difficult in the most deprived areas. One of the particular challenges, I think, in dealing, in engaging with people is about aspiration, about instilling in people that there is something better. Part of the challenge, of course, is that the old one I learned when the people said, let them go to somewhere really bad. So there may be people living in what you might perceive as quite a deprived area, but they view their lives to be fine. And I've lost count of the number of consultations I had in Glasgow Shettleston where people would say to me, to effect, I feel depressed, I don't know why, I've got no problems, I've got no money worries, I've got no family worries. And yet they were living in what to me seemed very straitened circumstances. But that wasn't how they perceived it. And I think particularly for youngsters, there is a real issue. And I was held up, like I think some of you were, on the M60 today. So the downside of that was I was 20 minutes late. The upside was I managed to hear Desert Island Discs, in which Ian McMillan, the so-called Bard of Barnsley, was giving his choices. But he told the story about writing an essay when he was in school, and he signed it Ian McMillan, future Nobel Prize literature winner. And his teacher took him aside and said, you don't get Nobel Prize winners from Barnsley. And I'm sure there are no teachers employed by your council who would say that to an aspiring Ian McMillan. But it nevertheless demonstrates just, I think, it made me reflect about how important aspiration is and to encourage and stimulate aspiration. Commissioning is a huge challenge in the new structures and the whole system restructure. System restructure is, I think, difficult for all the people who are involved in that change, and there's a lot of people in the country actually personally involved in that change and who don't know quite what they'll be doing in a year's time, and I think that's very challenging, and it's also very challenging for GPs and the GP consortia to pick up commissioning. In some places that will work quite well and relatively easily because there's been good history of good practice-based commissioning. In other areas it's a huge steep learning curve. This is not so much to do with commissioning, but this is an example of one response to the pressures of working in deprived practice. GPs at the Deep End is a group that developed in Scotland of the 100 most deprived practices. And they meet and they've produced a number of reports on the experience of working in particularly deprived areas and of having insufficient time and other resources to address the volume of need and demand. And the logo comes from a drawing that my old boss, Graham Watt, who's a professor of general practice in Glasgow, used, where he describes GPs working in affluent areas as swimming in the shallow end of a swimming pool, working hard, but at the shallow end. But the GPs in deprived areas are at the deep end, where their feet are not on the ground, but they're struggling to keep up. Opportunities. The RCGP is arguing that there are real contractual opportunities in terms of inequalities, and I know most of you are not here are not GPs, so I won't bore you with QOF and so on, but it's the quality scheme by which a significant amount of GP remuneration now comes, and in the RCGP response to the white paper, a QOF for inequalities was one of their suggestions, so that would mean that each individual practice had in some way to prove that they had an awareness of the kind of social determinants around them, and were doing something about it. Removing the ability to exempt patients, as I explained, for cervical screening, that has a potential to make inequalities worse. The other side to that, of course, is that would make general practice in deprived areas even harder, but also making a much bigger emphasis on prevention. Commissioning must be seen as an opportunity, particularly after the learning curve has been got through, but it must be seen as an opportunity. And I do think we need more information about interventions which work. Also, we're trying very hard to ensure that inequalities and social aspects of health get into GP training, get into the training in undergraduate medical schools, so that public health is not seen as that kind of boring soft subject that we can actually miss, but that people come out of medical school understanding these issues, and that subsequent training also incorporates them. The white paper does say that GPs do have, the consortia have this duty to promote equalities, and we hope that duty will be not as, a duty just sounds a bit vague, doesn't it? But that will be much, much firmer and clearer as to exactly how that will do. The Royal College of Physicians, in conjunction with a number of the other Royal Colleges, produced a statement this year on how doctors can close the gap. If you put that into Google, you would find it. But basically, it was about tackling the social determinants of health through culture change, advocacy, and education. And lots of the things I've mentioned appear in that. It does seem, particularly from the point of view, I think, of a consulting room, it does seem a really, really hard task to see people year after year, consultation after consultation, and wondering what impact you're making. Don't know if many of you have read Sebastian Barry, The Secret Scripture, but for those of you in healthcare, you might read the back of it in a bookshop and think it's a bit of a busman's holiday. But it's well worth reading. It's the story of an old lady, aged 90, in an asylum in Ireland. And Ireland are going through a care in the community type programme like Britain did, and so her psychiatrist, who's reaching the end of his working life, has to assess whether she's fit to be discharged. And she's been in for 40 years or 50 years in the psychiatric hospital, and the story is the story of their relationship and how they're both reflecting on the events that got her to be there, or she's reflecting on that and he's reflecting on his own life. And as a psychiatrist, he says at one point, as I do not seem able much to heal, then maybe I can simply be a responsible witness to the miracle of the ordinary soul. And of course, it struck me that maybe that's fine, that maybe that is appropriate for psychiatry. It certainly seems to me more appropriate for primary care, and much more appropriate for us to be thinking as we talk about inequalities and what we're going to do, that in the middle of all this are millions of miracles of ordinary souls. Thank you.